Hello students, today we will be talking about a part of anesthesia. In your surgery paper 2, you will find questions on anesthesia which will be compulsory. So in order to prepare on that, I am going to take a lecture starting with principles of general anesthesia. By definition, anesthesia means the inability to feel or perceive sensation. Most important is inability. So, the person who is anesthetized won't feel any pain or any other sensation during that period of anesthesia. A bit of history dates back to 4000 BC, that is about 6000 years back. Poppy, from which opium is extracted now, was first used for anesthesia. Later on, in Babylon civilization, they used hyoscyamus, and the Chinese used acupuncture. 650 BC, ethylene gas was made. Imagine, so far back. In 1540, Valerius Cordius synthesized ether. In 1800, the anesthetic effect of nitrous oxide was established. And in 1846, the first ether anesthesia was given in Massachusetts General Hospital, America. We have a triad of anesthesia, which consists of analgesia, that is, pain relief. Relaxation, the muscles must be relaxed in order to have smooth surgery. And hypnosis, that is, sleep. So, pain relief, muscle relaxation and sleep. These three make general anesthesia. Going back a bit to your anatomy, when a pain is given on the skin or any part of the body, there are two nerves which transmit the pain. One is a delta fiber and one is a C fiber. A delta fiber immediately transmits the pain, which goes through the spinal cord straight to the thalamus, and you perceive it immediately. Later on, what happens? The slow C fibers, which are unmyelinated, they start carrying on this pain sensation, and the after pain, which occurs after an injury, is due to the C fiber. What is the physiology of sleep hypnosis? There are several theories about the drugs, how they produce the loss of memory and consciousness. So far, no conclusive proof has been established. A recent theory proposes there is a dissociation of the fibers inside the brain where the pain and all the other sensations are struck off. And this is controlled by the executive control system inside the brain. Coming to muscle relaxation, you must have read in anatomy how the muscle is activated. There is an action potential from the nerve which stimulates the sarcoplasmic reticulum. The muscle contraction starts when actin and myosin binds. This is continuously recharged with the help of ATP. When the action potential is stopped, the stimulation stops, the calcium from the sarcoplasmic reticulum is pumped back, and the link between actin and myosin is broken, so the muscle relaxes. What are the general anesthetic drugs? For sleep or hypnosis, we have short-acting barbiturates like thiopentone sodium or a drug called propofol. For pain relief, analgesia is produced with opioids like morphine, pethidine, fentanyl, or non-steroidal anti-inflammatory drugs like diclofenac sodium. Muscle relaxation can be of two types, the drugs used. One is a depolarizing muscle relaxant. This is an agonist of acetylcholine and it works at the acetylcholine receptors, but because it is not quickly metabolized, there is a fatigue in the muscle, and so the muscle ultimately relaxes. This is a very short acting period which this can act, and then the muscle comes back and the muscle relaxation is over. The main drug we used for relaxation is the non-depolarizing relaxant. This is a competitive antagonist of the acetylcholine receptors. It goes and binds to the acetylcholine receptor and prevents the acetylcholine from acting. In pharmacology, you must have read about these things, but I am just mentioning them, and if you are in doubt, don't think twice to ask again. I will tell the relevant person here. If you have any query, they are going to send it back to me, and I am going to answer it on your query. There are another type of inhalation, the anesthetic drugs called the inhalational agents. They are in liquid form and they need a vaporizer in the anesthesia machine from which it is vaporized and goes into the system. It acts similar to the others, and executive control system is the place where it ultimately acts. What are the steps of anesthesia? First, when the patient is taken up for surgery, the patient must be investigated. Any abnormal investigation is immediately corrected and the patient is sent to the OT. If there are coexisting diseases like diabetes, hypertension, then what happens is we refer these patients to the appropriate department who control the patient, and then the patient comes back after getting controlled, so that the patient, we call it optimization of the patient. The patient is optimized. What are the baseline investigations we do? A complete hemogram, urine RE, blood sugar, urea creatinine, thyroid hormone assay, ECG, chest X-ray, and in cases where we find that there can be a compromise, or in all patients above the age of 50, we do an echocardiography. Any other special investigation is done according to requirement. What are the steps of anesthesia? After the patient is optimized, the patient is posted for surgery. First, we pre-medicate the patient. This is to allay the anxiety the patient will be having for undergoing surgery. So, the day previous, the anesthetist goes and makes friendliness with the patient, tells the patient that there is nothing to worry, you are going to be taken care of. If you go into the road, the amount of the chance of you getting any problem if you are traveling on the road is same to the surgery also statistically. Then what we do after we speak to the patient, we have to do something to diminish the pain. And once we diminish the pain, the reflexes are all toned down. The patient, usually these patients with anxiety, they hypersecrete from all their glands. So to prevent hypersecretion from the glands, we give the patients anesthetic drugs to counteract this hypersecretion. They are the anticholinergics like atropine, glycopyrrolate, etc. Patient may become nauseating because of the thought of surgery. So an antiemetic like ondansetron is given. Sometimes opioids are also added so that the patient is calm when the patient is being transferred to the OT. Patient is also given a sedative like benzodiazepine, like midazolam, so that the patient can be semi-sleeping. The stomach should be empty for 4 to 6 hours prior to surgery. An intravenous line is secured with normal saline or 5% dextrose in one hand, preferably on the left hand, and the patient is brought to the OT table. So now the patient is on the OT table, we must start monitoring the patient. What are the monitoring? One is we fix the ECG leads, we see the ECG. If there is any arrhythmia, tachycardia, heart block or any myocardial injury, we can immediately give appropriate drug so that nothing untoward can happen. Pulse oximeter is put to see the peripheral oxygen saturation. A non-invasive blood pressure monitoring is attached, which automatically monitors the blood pressure at a time interval which we fix. The end tidal carbon dioxide concentration, it is very important that we are giving oxygen to the patient. What we don't know if the carbon dioxide inside is coming out or is being retained inside the body. If there is hypercarbia inside the body, the patient may face a lot of problems, like patient may start sweating, patient will have high BP, and patient recovery will be very, very delayed. So the end tidal carbon dioxide concentration, we always monitor that so that adequate carbon dioxide is also coming out from the lungs. And the IV channel should be checked to be so that it is adequate. Now we go into the main general anesthesia. It starts off with induction. Patient is first put a face mask on the patient's face, and he is pre-oxygenated for 3 to 5 minutes so that the residual nitrogen inside the lungs is washed out to a bit. Now we put the patient to sleep, hypnosis, with thiopentone sodium or propofol, which is administered IV. Once then we give a depolarizing muscle relaxant like scoline. Scoline is given and the muscles are relaxed. Once the muscles are relaxed, we put the laryngoscope inside the mouth and we see the vocal cord and put in an appropriate size endotracheal tube. And these endotracheal tubes are all cuffed. That is, the tube is like this and there is a cuff which here we put in air, and the cuff inflates like a balloon, and so the patient, if a patient regurgitates from the stomach, the regurgitating fluid will not enter the lung. That is the main idea of a cuff tube. Oxygen and nitrous oxide are then given in a ratio of 1:2. That is 67% nitrous oxide, 33% oxygen through the anesthesia machine. And if you have not given an analgesic before, we put in an analgesic IV. Once the patient is induced, we have to maintain the patient. The overall idea of maintenance is patient must be unconscious, there should not be any memory of whatever the patient has been throughout the surgery, so there should be amnesia. Patient should be immobile, that is relaxed, and patient should be unresponsive. There should not be any twitching or movement of the patient. Oxygen and nitrous oxide are continued. If required, an inhalational agent through the vaporizer is also administered if we see that there is too much of sympathetic stimulation, which may cause tachycardia, hypertension. Then we add an inhalational agent. If the patient has high blood pressure during the course of the maintenance, we give glyceryl trinitrate. Another point is, once the depolarizing muscle relaxant wears off, then we start the non-depolarizing muscle relaxants and maintain the patient only on non-depolarizing muscle relaxant till the end of surgery. If the patient has tachycardia, an IV beta blocker is given to decrease the pulse rate. This is a typical machine, anesthesia machine. The anesthetist is working there. This is the monitor, and this is the vaporizer through which the inhalational drug is given. This is the circuit which goes into the patient, and here the endotracheal tube enters the patient. Once the surgery is over, we must bring the patient back from anesthesia. So this is called, the procedure is called reversal of anesthesia. All the drugs which we have been using are potentially toxic agents. So first thing we do is we switch off the nitrous oxide, put the patient on 100% oxygen. Then when we see that the patient is taking a small amount of breath, we start recurarization. Curare was a drug used by South Americans. They used it to kill the animals which they were going to have for eating. Curare is a drug which is found in South America, and from that the first muscle relaxant was synthesized. But these days curare has gone into disuse because it has had a lot of bad effects, or a lot of bad side effects. So, but the word curarization remains. So, recurarization is that the patient is brought back from the relaxation. Here, a drug called neostigmine is used. This is an anticholinesterase, and it is hydrolyzed much slower than acetylcholine. So what happens? This anticholinesterase goes and blocks the acetylcholine receptors, and slowly it replaces the relaxant drugs, the depolarizing muscle, the non-depolarizing muscle relaxants from the receptors, and the patient slowly recovers from the relaxation. There are a few side effects of neostigmine, which include bradycardia, hypotension, bronchospasm, and increased respiratory secretion. These are the bad effects of neostigmine when we administer it. So what we do, in order to counteract these side effects, we always add atropine or glycopyrrolate with the neostigmine, so that these bad side effects do not occur. Once the muscle relaxation effect is reversed and the patient starts breathing again on its own, we determine the level of consciousness by asking the patient to open the eyes, show the tongue, move the head, and if we find that patient is adequately awake, recurralized, there is no effect of any sedation, then what we do, we slowly take out the endotracheal tube after sucking the mouth, which usually has secretion during this period of anesthesia. Once the tube is taken out, we put the face mask, which we started off initially, back on the patient's face, and for 5 minutes we ask the patient to take spontaneous breathing. If the peripheral oxygen saturation through pulse oximeter is found between 96 and 100%, then the patient is transferred from the OT to the recovery room. In the recovery room, all the monitorings are done: ECG, pulse oximeter, NIBP. N-divalent carbon dioxide is not done because it is not possible with a face mask or a nasal catheter. If all the parameters are stable, the patient is sent back to the ward after 30 minutes to an hour. The effect of anesthesia has worn off by then. Thank you all, and if you have any question, you can send it to the appropriate authority and they will send it back to me, and I will definitely answer your questions. Thank you very much.